start the next talk, which is by, again, a very active member and advisory board member of our International Diabetes Expert Conclave, Dr. Rajiv Kovil. He is an experienced endocrinologist. All the audience knows him, working for more than 20 years now. And we have a talk on, can TIR replace HbA1c, a talk that has been on demand in today's time, because we are questioning the old ways of monitoring and coming up with the new ones.
Thank you so much. Thank you so much, Anjali. Thank you, the whole team. Can I get to share? Thank you, Neeta, for intentionally logging off 5 minutes before, and Sanjay for extending my time. I'm going to talk on whether TIR will replace HbA1c, and it's something that all of you all have listened to, and I would have no conflict of interest other than I believe that I would be paid in kind later on. This is a dialogue between CGMS and SMBG, and we know that CGMS has MERD, that is mean absolute relative difference, and today we are using CGM and TIR a lot. But 2 decades back, there was a publication in Critical Care which said that this point of care devices that we use can never help us in identifying hypo and minimize glucose variability. It's almost 2 decades later that today, and this was done in critical care patients, that probably is becoming a reality where we are getting to see the problem. And why we need to do this is that CGMS, whether it's professional or intermittently scanned or real time, puts the patients at the center, and the patient, then we are able to get a better insight into patients' lifestyle patterns, which has a huge impact on the overall outcomes as such. We all know this slide where if we overlap CGM on SMBG, we see a lot of variability. The difference that we get between a photograph or a videograph, a Holter or an ECG, a 24 hours ABPM versus an office ABPM, or a trailer and a movie, is that kind of difference we get between a CGM and an HbA1c. If you look at the history of using HbA1c, it has evolved over the last 50 years from using total GHB to now HbA1c. But today you also have TIR based consensus based on HbA1c itself. Now let's look at limitations of HbA1c as a surrogate marker. Again, it has not been very optimal, because if you look at the patients who have achieved HbA1c is very, very low. Though HbA1c has been the surrogate marker for glycemic control for last 40 years, we still don't know a good glycemic control that can prevent cardiovascular disease. We know that 1.5 decades back, we had Accord, VADT, and Advance, where people went like cowboys to reach an HbA1c of normoglycemia. Whether the drugs used or the strategy was wrong, we still don't know. But we had adverse effects. And also we know from the DEVOTE 2 study that fasting glycemic variability significantly increases the risk of hypoglycemia, MACE, and all-cause mortality. It also tells us from the VADT study that hypoglycemia is the second highest risk factor to the occurrence of an event. So hypoglycemia, glycemic variability, and we know that hypoglycemia is the tip of the iceberg of glycemic variability. Hypoglycemia is associated with an increased risk of cardiovascular events and mortality. Whether hypoglycemia is a risk factor or a risk marker, it surely identifies vulnerable people who are at very high risk for cardiovascular death and all-cause mortality. Again, HbA1c does not identify hypoglycemia. We know that we could have 2 patients with different variability having similar HbA1c. Is a poor surrogate marker for hypoglycemia. We surely know this also. Again, a lot of conditions can affect HbA1c, and as you can see that most common being thalassemia, hemolysis, cirrhosis, hypothyroidism, vitamin C, blood loss or blood transfusion, hemodialysis, most common in practice, which can affect HbA1c. Importantly, before we get into TIR, the first question that we need to answer or we need to address is glycemic variability important, and is it the missing link between sugar control or all kinds of complications. So there was this study which was published 5 years back called as the flat sugar study. The flat sugar study again took into the background that HbA1c does not give us is not a true indicator of glycemic control, and probably we need a better indicator, whether it would be a glycated albumin, fructosamine, anhydroglucitol, or whether interstitial fluid glucose picked TIR, we still don't know, or PIR, point in range. But this was a hypothesis generating study which said that glycemic variability could contribute to adverse medical outcomes. And today, because we have diagnostic tools and available treatments which reduce glycemic variability, they tested the hypothesis of whether we could reduce overall glycemic variability, keeping the HbA1c the same between two prospectively treated groups, and whether we could look at reduction in inflammatory markers or cardiovascular markers, and reduction in albuminuria or any Holter monitored ECG abnormalities. So basically you had two groups. One was on basal bolus insulin, the other one was on basal insulin plus a GLP-1. In this case, it was exenatide on the background of metformin. As you can see, at the end of 26 weeks, you had similar HbA1c reduction, but the coefficient of variation in CGM was much different, where the basal bolus insulin had a large coefficient of variability as compared to basal bolus insulin. So what it showed is that MAGE was improved. Glipulin is basically patients on basal insulin plus GLP-1. There was no severe hypoglycemia. Body weight was lower. Inflammatory markers, including IL-6 and highly sensitive CRP, were lower in the group which used basal insulin plus GLP-1 and had lesser glycemic variability. Certain ECG abnormalities also lower in this group where the variability was lower. So again, this was a proof of concept. We had 200 patients, but it was a proof of concept that you could actually achieve similar HbA1c with two different types of treatment and could reduce a lot of inflammatory markers. Probably that is the missing link. We need a larger trial to actually prove this hypothesis as such. Now, what is time in range? And the guidelines suggest somewhere between 70 to 180. For people with type 1 and type 2, the time in range should be more than 70% in 70 to 180 and less than 25% in the time above range, that is more than 180 and less than 250 and less than 5% more than 250. Time below range, or TBR as it is called, less than 70 to 54, less than 4%, and severe hypoglycemia less than 54, less than 1%. You can relax the time in range slightly in people who stay alone, people who are hypoglycemically unaware, and type 1 and type 2 were very high risk, probably CLDs, CKDs. Staying alone, we could have a TIR of close to 50%. Pregnant women with type 1 diabetes, again, there is a change in the TIR. The target range is between 63 to 140, and we should try to target at least 70%. GDM and pre-existing diabetics, we should target at least a 90% of TIR for pregnancy, which is 63 to 140. Now, most importantly, whether this time in range as an outcome measure, has it been validated? And this is the proof of that, where the study evaluated the association of TIR of 70 to 180 with the development and progression of diabetic retinopathy and development of microalbuminuria in the DCCT. Any strategy study is best to be done in people with type 1 diabetes because that doesn't have insulin resistance, and glycemic strategy can easily be picked up. Two retinopathy based cutoffs is what we used for HbA1c as well as fasting and PP. So this validation of TIR in a population with type 1 diabetic in a longitudinal study like DCCT again makes a lot of sense. And what it showed is that the TIR for intensive groups was close to 50%, and TIR was 32% in those developing retinopathy versus 44% not developing retinopathy. Similar with microalbuminuria. And as you see, as the TIR goes down, the frequency of microvascular complications, which we all know is directly linked to glycemic control. And here, glycemic variability, here you can see in a landmark study like DCCT, there is validation of TIR. Again, if you look for each 10% less TIR, retinopathy progression decreased by 54%, 64%, and microalbuminuria by 40%, again with a very significant p-value. If you look at in type 2 diabetics, also TIR was significantly associated with diabetic retinopathy, and probably we can use TIR in type 1 as well as type 2 diabetes. Again, every 10% lesser TIR increases retina, nephro, and neuropathic risk as well as carotid intimal media thickness. Now, would we be using TIR or CGM or real-time CGM in hospital settings in future? There are a lot of studies, especially with the advent of telemedicine and with usage of flash glucose monitoring and Dexcom G6, as well as the iPro 2 machines. We are now able to do a remote monitoring by healthcare providers, and probably that would make treatment easier. And if we could have free streaming blood glucose, as this paper suggested in November 2020, though it was done in a non-ICU setup, where Dexcom G6 with the help of Bluetooth through a smartphone, an Android smartphone, was centrally beamed to a nursing station. And as we have temperature, pulse, respiratory rate, and BP, there was a streaming of blood glucose to the central station, and patients were remotely controlled. And by doing this, they found that the hospital stay was much better, and also outcomes were better. This prompted the RSSDI to take up their campaign of defeat diabetes and declare glucose as the fifth vital sign. Again, conclusions that we could use CGM in non-ICU setting. There are studies being done in ICUs as well. Let's look at some guidelines. The ACE says that CGM should be considered if glycemic target is not reached within 3 months. Use of personal CGM should be considered when the patients have recurrent hypoglycemia. We should consider a personalized CGM. Again, we had done this evidence of iPro 2 in real life almost 8 years back, got published in the JAPI around 5 years back. We have an Indian consensus on CGM. I'll come down to the final few studies where finger stick, HbA1c, and CGM are all complementary. Finger stick testing gives us a snapshot. CGM gives us the whole picture. HbA1c is where a lot of our outcome related studies are based upon. So all of them are complementary, none of them are replaceable, but probably TIR is emerging as a very powerful tool, and whether it replaces HbA1c in future will depend. But technology has surely improved time in range, and as you can see from SMBG usage and almost coming to a hybrid pump, we are able to improve the time in range quite a bit. I will leave you with a little bit of thought on one of my patients. This is a pregnant type 1 diabetic who was very reluctant to go on a pump. She's now on a 640G with a sensor augmented pump. She's almost 30 weeks pregnant. If you look on the left hand corner, the one in blue is her 30 days period from 5th of July to 3rd of August. The B is the 5th of June to 4th of July. And if you look on the left lower corner, you see her time in range. A pregnant type 1 diabetic is reaching a time in range of 81%. I would still say there is scope for improvement because we are around 12 to 15% in time below the range, but her HbA1c is 5.5. Her sensor wear, as you can see, is close to 94 to 87%. So technology has made us achieve this kind of time in range in pregnant type 1 long-standing type 1 diabetics. And this is what we can change, and we can make effective change in the quality of life and in the lifespan of people with both type 1 and type 2 diabetes. So in summary, I would say the CGMS assists discovering a lot of glycemic variability, and we know that fasting glycemic variability is linked to outcomes, and probably we need to use a lot of this powerful tool to make sure that we make our patient's life easier in the long run. Thank you all for a patient hearing. I hand it to the organizers and Dr. Arvind, who's really, really keen to come in. Thank you so much.
Yeah.
Let's upgrade. Thank you.
Thank you so much, Rajiv, for bringing in TIR and A1C so very nice.